Excellent. And thank you very much for coming on time, Dr. Hassan Ahmed. In 2 seconds, we'll start. Ladies and gentlemen, I'm so delighted to invite you tonight for the Mega Learning webinar. Most probably this is the 99th session since we have started on 20 of April 2020. This webinar is exclusively very, very important for us because it has 2 big lectures in anesthesia and intensive care. I will leave the speakers to the moderator to introduce, but tonight we are delighted that to have 2 iconic, distinguished, eminent moderators for this webinar. Dr. Yasser Reda is a senior consultant, anesthesiologist, and interventional in medicine in Hamad Qatar Corporation, and he is multiple, qualification, and I can't read all of them tonight. Dr. Yasser Reda is honoring us by his presence tonight and is staying with us for moderator. The other moderator is Dr. Sharmili Sinha, and she's a senior consultant critical care medicine Apollo Hospital in India. She earned her medical doctorate degree and the EDIAC European Society in Intensive Care Medicine from London, and she is a fellow of Indian Critical Care Medicine. She has advanced training in critical care medicine in Australia. She has a very, very long CV. I don't want to waste our time tonight for the CV because she's given us two iconic lectures before, and Dr. Sharmili Sinha is one of the senior consultants in India. She in Indian Critical Care Society, and she has a special interest in neuro critical care medicine. Most probably, you are going to see her very often in the MEGA platform. I will leave the webinar now to our colleagues, Dr. Yasser and Dr. Sharmili Sinha, to introduce our distinguished speakers tonight. And I would like to welcome all of you tonight. And I'm so happy to see this number of attendees and this number of support by all the senior and junior people all over the world. Thank you so much for coming tonight. And all of you, Dr. Yasser and Dr. Sharmili. Thank you.
Thank you, Dr. Saad, for your kind words of appreciations. And thanks again to Team Mega for effortlessly and successfully conducting this academic sessions. So tonight, as Dr. Saad has already mentioned, we have very interesting sessions on 2 topics and very eminent speakers for both the topics. And we know that airway management is the first step in saving any life. But when it is conducted in the operation theater, it is usually elective and we have all the armamentarium around us to conduct the procedure safely in a planned manner. But when we have to do this airway management in the intensive care unit, situation is entirely different because it will be an entire different game altogether. Because conducting the airway procedures on a patient who is unstable, critically ill in an intensive care unit in a situation of panic and anxiety puts forth a lot of challenges. So how you do it in the setting of intensive care unit, how it differs and why it differs, we'll hear it from one of the eminent speakers tonight. We have Dr. Hassan Ahmed with us. He's Assistant Professor Anaesthesiology and Chief of Intensive Care and Emergency Medicine at KPC Medical College, Kolkata in India. He has done his diploma in anesthesia and also done DNB in anesthesia. He has completed his European diploma in intensive care medicine, and his special interests are in the area of mechanical ventilation, hemodynamic management, sepsis management. So over to you, Dr. Hassan, for your topic.
Thank you, Dr. Sharmili, and thank you, Dr. Saad, for giving me this opportunity to participate in this mega event of online anesthesia courses. Today, I will discuss about the difficulty airway management, how it is different from operation theater. And I have initially practiced for 5 years as a pure anesthetist in a high-end center, and later on switched to, for last 10 years, switched to the intensive care unit. So coming from the operation theater, once I entered the ICU, see that the entire ball game is different. So traditionally, the airway management of critically ill has followed the same principles as intubation in the OT. That same laryngoscopy, that same intubation, endotracheal tube, that same position. So the principal management is same, but there is a difference that it requires a qualitatively different approach when managing airway in ICU. Why? The one significant difference between the two environments is that when it is encountered, the intensivist does not have the option of postponing the procedure for another day, because in ICU, it is always a life-saving intervention. So there was an interesting article published in 2011 in Indian Journal of Anesthesia, that tracheal intubation in ICU, is it a life-saving or a life-threatening things? So as we have seen also in our practical situations, intubating a ICU patient who is in already coma or in shock is very difficult task overall. And importantly, there is many times there is death immediately or immediately after the intubations. So how it is different from the operation theater? So airway management in intensive care patients differs significantly from the surgical procedures in the operating room. The critically ill patients have less physiological reserve and complications are more common in this group of patients. And maintenance of a patent airway, adequate ventilation and pulmonary gas exchange is a very important in critically ill patients. So the common difference is that in intubation in the operation theater, what we got a skilled anesthetist. We get elective intubations for already prepared patients, optimized patients. The patient's condition is optimal regarding his fasting status, regarding his hemodynamic status, all the optimization done beforehand. Then if we can find a difficult unanticipated airway, we can wake up the patient. And generally, this group of patients are stable patients. They are good. They are having a very good physiological reserve. But in intubation, in emergency department or in the intensive care unit, what you got in your hand, varying skill levels from a junior level of RMO to a senior level of expert intensivist. You can get anyone in during different time period of the day. And little or no time for patient preparation. If a patient suddenly collapses, you don't have any time to optimize the patient. You straightforward, you have to rush to put a endotracheal tube and put the patient on mechanical ventilator. Then there is suboptimal environment. There is space scans. You cannot get the right position as you want. And you cannot wake up the patient because it is an emergency. You have to put the tube. So you cannot wake up the patients. You cannot postpone the procedure. And most of these patients are unstable patients with little or no physiological reserve. I mean, coming to one by one. So why it is challenging in ICU setup? Because difficulty is more of physiological rather than anatomical. Whenever we talk of any difficult area, mostly we thought of anatomical difficulty, like inadequate visualization of the vocal cord. There may be facial trauma, facial burns. So that is the most of the anatomical one. But in ICU, what we see a group of patients who are more of a physiological difficulty. They are often in shock. They are already hypotensive or on multiple vasopressors. They are severely hypoxemic on oxygen support. So the standard pre-oxygenation used in these optimized surgical patients would fail to serve in a critically ill patients. So physicians, other than anesthesiologists, are reluctant to use muscle relaxant. There may be sometimes multiple organ failure like kidney failure, liver failure. They are not familiar with these muscle relaxants. They are not using it day to day. So they are a little bit reluctant to use this muscle relaxant. So sometimes a normal airway may become a very difficult one at times. So why it is again challenging in ICU? Lack of airway expertise is a high risk for multiple intubation attempt, then multiple trauma, esophageal intubation and intubation failure. As a result, there are increased incidence of life-threatening complications like high percentage of cardiac arrest or hypoxic brain damage. So issues like the need to re-intubate in ICU is very common. Many patients will go for a trial extubation. There may be patients accidental extubation. So these patients need re-intubation frequently in ICU. And re-intubation is always difficult in ICU because there may be unexpectedly difficult in hypoxic, distressed or uncooperative patients. So these articles highlighted the problems and challenges into three factors. One is the ICU related factors, second is the patient related factors, and third is the operator factors. In ICU related factors, what we have seen, there is lack of space around the patient. There are poor access to patient's head end, poor lighting, trained help is not always available like the operation theater. Then airway devices such as fiber optic bronchoscopes, supraglottic devices, and video laryngoscopes are not readily available in many ICU. Not all ICU, but many ICU. Then timing, emergency intubation may occur anytime, may be required at any time in the day or night, and there may not be adequate expertise help in that moment. Then coming to patient factors, the airway assessment is always difficult or impossible due to lack of time or patient being uncooperative. You cannot do a proper malampati by asking the patient to sit up and you do the malampati. Then risk of aspiration. These patients many times they are full stomach. There is gastroparesis associated with the critical illness or patient not fasted and requiring emergency intubation. There is challenging anatomy maybe due to trauma patients like maxillofacial trauma, cervical spine injury, airway injury, burns, retropharyngeal abscess, etc. Again, inefficient pre-oxygenation because of multiple factors like the disease may cause shunt, ventilation, perfusion mismatch from the underlying illness. There is reduced functional residual capacity. So there is a possibility always of a rapid desaturation. So there is lack of physiological reserve, often leads to this rapid hypoxemia during a very short period of hypoxic or apneic period. Then patient may be hemodynamically unstable due to critical illness itself or the drugs used during the facilitated intubations. All the induction agents, mostly except ketamine and intermediate, they cause hypotensions. Then waking up of the patient is not an option because unlike in the operation room because of the disease itself and the emergency situations. Then there are some operator factors like limited airway training and poor airway management skills. There may be inexperienced junior doctors and stress like any of the patient ICU or operator related factors alone or in combination may produce extra stress of the situation. How to predict anatomical difficulty in airway management in an ICU patients? So there is only one validated airway tool that has been used in critical ill patient is the Makocha score. So there are total 12 in number. 12 the score is total 12. M for malampati is class 3 and 4. Then obstructive syndrome. Then C for the reduced mobility of the cervical spine. Then O for limited mouth opening that is less than 3 centimeter. Then factors related to the disease pathology like coma, patient of severe hypoxemia. Then factor related to the operator like most of the time the non-anesthesia is doing the procedures. And a score of 3 or greater predicts the difficult intubation. Coming to the physiological difficulty that is mostly seen in our ICU patients. The predictors of cardiovascular collapse during and after endotracheal intubation, the most common predictors are hypoxemia, pre-intubation hypotension, and the shock index. What is shock index? Shock index is the heart rate divided by systolic blood pressure. The normal shock index is usually 0.7, and any value greater than 0.9 indicates a higher mortality. Now coming how to prepare to deal with these challenges. So the most important key message is resuscitate before you intubate. So don't jump, try to optimize the patient as soon as possible and as much as possible. How to handle with the hypoxemia? So the pre-oxygenation and apneic oxygenation should be performed in all critically ill patients. In operation theater, what we do with a McGill circuit, we do a pre-oxygenation for 3 minutes with 100% oxygen. But in those patients who are already hypoxemic, who are already in severe ARDS, we have to pre-oxygenate more, and mostly we have to target a saturation of 96 to 100% with an NRBM with a maximum flow rate of 115 liters per minute, or we can use a back valve mask with a nasal cannula at 15 liters per minute. And if the oxygen saturation is still not maintaining with this technique, if the saturation is less than 95, then best preparation is to use an NIV or back mask ventilation with some PEEP effect to improve the alveolar recruitment and oxygenation. Because these patients are hypoxic, not only in ICU, but patient may have to take to OT for some emergency operation as well. So we have to pre-oxygenate to all the critically ill patients to achieve a certain level of oxygen saturation, and all patients should be positioned in backup head elevated position if possible. So try to intubate even in semi-recumbent or recumbent or head elevated positions. That will help you to improve your pre-oxygenation before the actual intubation procedures. The next important issue in ICU, the physiological difficulty, is the hypotension or increased shock index. Most of these patients in ICU, they are on multiple vasopressors like noradrenaline, vasopressin, dopamine, like that. So first important thing, those sometimes patients come with hypovolemic shock in mostly trauma ICU. So establish a good IV access, that is the very basic. Then preload if no fluid overload is there, no cardiogenic pulmonary edema is there. You have to optimize the preload, and always be aware of the right ventricular failure, because many of these patients may have a right ventricular failure, and if you add extra fluid to that, the patient may go into the acute decompensated heart failure. So you have to be careful of that. Then early use of vasopressors or inotrope to optimize the systolic blood pressure on the mean arterial pressure. Then use hemodynamically stable induction agents like ketamine or etomidate. There are many publications regarding that you can go through. Use judicial use of muscle relaxant. Try to use a very short-acting muscle relaxant. And those muscle relaxant, if you go for a long duration of muscle paralysis, you can use the most hemodynamically stable muscle relaxant like vecuronium. Then patients with severe metabolic acidosis, these are challenging patients. Patients with high lactic acid, those patients of diabetic ketoacidosis, the apnea may kill. So try to intubate them awake, either with a preservation of the spontaneous respiration. Sometimes these patients are so moribund, and even a topical lignocaine can help you to put an endotracheal tube and put on mechanical ventilation without using any muscle relaxant or induction agent. So again, there is an interesting article, that is All India Difficult Airway Society. They have put a guideline on 2016 regarding the tracheal intubation in the intensive care unit. There is another guideline by the Difficult Airway Society of the UK. So all of the guidelines say that tracheal intubation in critically ill patients, first you have to do very well pre-oxygenation and go for the checklist like position, head up if possible. Then access the airway, identify the chicothyroid membrane beforehand, because you may have faced a difficult anatomical airway and you may have to go for an emergency chicothyroidotomy. Then waveform capnography is must for all these patients. Then pre-oxygenate with either a face mask or a NRBM or an NIV, or even if you can use, if it is available, then you can use a high flow nasal cannula to optimize your patient's oxygenation level before the procedure. Then optimize the cardiovascular system, as I have told. Use the inotrope or vasopressor beforehand to improve the main arterial pressure or the systolic blood pressure, and share plan for failure with everyone in the team. So make a team, then assign the role of each members in the team, and then share the plan. Then plan A, that is the tracheal intubation using a laryngoscopy, but do not attempt more than 3 times, and do not make the same mistakes every time. So continue, maintain the oxygenation, continue the nasal oxygenation or NIV or HFNC, whatever you are using. Then the face mask or ventilator between the attempts, and then neuromuscular block, then video or direct laryngoscopy. If you have a video laryngoscopy, then it is good. Then you may need external laryngeal manipulations and remove the cricoid pressures during the intubations. So if you have failure, if you success well, if you have failure, then call for help, and then get the video laryngoscopy. Then again get the front of neck access. So declare it as a failed intubation if you are not successful even after 3 attempts of laryngoscopy and intubation. Then go to the plan B, that is the rescue oxygenation technique. Either you can use a second generation supracloactic airway device, or you can again pre-oxygenate the patient, stop the procedure for some time, for a few minutes, and then take a second person's help, use the different airway adjuncts and the manipulations, and again go for maximum 3 attempts, not more than that. And if you are success, it's well. If you fail, then declare it as a cannot intubate and cannot oxygenate situation, that is CI-CICO situation. And then there is separate algorithm for the CI-CICO technique. So call for help, declare it a CI-CICO situation, and go for the plan D, that is the front of neck airway access. That is either a emergency chicothyroidotomy or emergency tracheostomy. If possible, extend the neck, ensure adequate neuromuscular blockade, continue the rescue oxygenation with all the device you have, and exclude oxygen failure and blocked circuit. And then scalpel chicothyroidotomy. There are many ready-made sets available nowadays. If you don't have, you just open the chicothyroidotomy membrane with a scalpel, insert a bougie, and use a 5 or 6 millimeter of internal diameter of endotracheal tube. Just insert it and ventilate with a bag mask to ensure that patient does not suffer from a hypoxic cardiac arrest or hypoxic brain injury. So this is a reference for your reading, published in 2018 in British Journal of Anesthesia. So again, the guidelines is that the most important thing is prepare your patients. So reliable IV or IO access, optimize the position, sit up if possible, use a hard mattress, identify the chicothyroid membrane, ready for the awake intubation if you have a fiber optic bronchoscopy, then optimal the oxygen, pre-oxygenation with 3 minutes with the monitoring of oxygen saturation and waveform capnography, consider a CPAP or NIV, and optimize your patient state like fluid, pressures, or inotope, whatever is needed. Aspirate the nasogastric tube to make the stomach empty, and delete sequence induction if possible. And if the patient have a history of allergy release like burn patients, you should avoid the succinylcholine. Then prepare the equipment beforehand, like apply all the monitors, SpO2 monitor, waveform monitor, and they are showing the running the status that ensure that, and then check the all equipment list like tracheal tube of different sizes with cuff checked, then direct laryngoscopy of different size, video laryngoscopy, bougie or stellate, working suction machines, different type of supraglottic airway devices like intubating LMA, then the nasal airway, flexible scope, and front of neck access set, and check different drugs like consider ketamine, use muscle relaxants that are mostly hemodynamically stable. You may use the opioid like fentanyl also. Then pressure and vasopressor and inotope agents should be ready in an infusion pump and maintain the sedation. Then prepare the team, allocate their different roles like team leader role, first intubator role, second intubator role, keep quiet pressure by someone, intubator's assistant, different drugs, monitoring patients, then manual inline stabilization technique, and assign the role who will perform the front of neck access, and who do you call for help, inform them beforehand, like your ENT colleague or like that, and who is noting the time, and then prepare for the difficulty. Can you wake up the patient? If it is not possible, then verbalize the airway plan, like plan A, plan B, plan C, and plan D, as I have discussed. So there is a intubation bundle components that is suggested in the Indian Journal of Anesthesia articles, just like a ventilator VAP prevention bundle, just like the COTI bundle. They have suggested 10 intubation bundle components. The components are 4 in the pre-intubation, 2 in the during intubation, and 4 in the post-intubation bundle. So first one is presence of 2 operators at least if possible, then fluid loading in absence of cardiogenic pulmonary edema, preparation of long-term sedation, then pre-oxygenation for 3 minutes with either a NIV in case of acute respiratory failure, or pressure support between 5 to 15 centimeter of water to obtain an expiratory tidal volume between 6 to 8 ml per kg. And then during intubation, rapid sequence intubation using etomidate or ketamine combined with succinylcholine, or you may use rocuronium as well if there is any contraindication to succinylcholine, and Selix maneuver. Then in the post-intubation time, there are 4 bundles that are immediate confirmation of the tube placement by capnography, norepinephrine if diastolic blood pressure remains low, and initiate long-term sedations and initial protective lung ventilations. So in summary, the life-threatening complications during tracheal intubation in critically ill patients in ICU are always frightening. So recognition and optimization of anatomical as well as the physiological factors are important key for successful airway management in ICU, and acquiring knowledge and expertise and adherence to defined strategies and algorithms can resolve most problems in airway management in ICU. Thank you very much. These are for reference reading. Thank you so much for patience hearing.
Thank you, Dr. Hassan. That was a very elaborative and informative talk. I think you very nicely covered all aspects why we face difficulty or challenges in intensive care unit compared to a patient who needs intubation in the operation theater. So situation is really very different and unique in the setting of ICU. So I do not see any much, I can see probably one question has. So one doctor wants an answer for a question, that is, what type of video laryngoscope do you prefer?
So whatever video laryngoscope you are available in your ICU, I think that is sufficient. There are 2 or 3 companies that make this video laryngoscope. So whatever video laryngoscope your setup is, you can use that.
Yeah, so you meant to say like whatever basic or whatever modified kind of laryngoscopes do we have, that should be sufficient. Because I think whatever one is used to in his or her unit is usually better to use in those semi-emergency situations.
Two types of video laryngoscope. One is that handheld screen is there on the that is mounted on the handle, and second one is with the optical tube we can see in the big monitor as well. So anything is available will be sufficient.
Okay, thank you. I think there are no other questions that I see. So I have just one question for the sake of audience and just for the sake of discussion, because it's very important, especially after this COVID pandemic. Now, what kind of special or kind of precautions or tips would you like to share with our audience for a patient who has been on a non-invasive ventilation for some time, and now you have decided for some reason to put him on invasive ventilations? So what kind of challenges or complications would you anticipate, and what precautions would you take in specifically?
Particularly this type of situation we have faced mostly in this COVID pandemic. We are trying to mostly put those patients on NIV, and then sometimes they are even it is not possible to maintain the oxygenation, and we have to put those patients on ventilator. Anticipate difficulty in this situation, because once you remove this NIV to do a video laryngoscopy or non-laryngoscopy, whatever, at same moment will become hypoxemic. They are rapidly desaturated. So what we do in our hospital, we put those patients on HFNO for the temporary. We remove the NIV mask and then put on the HFNO. So the mouth opening is free for us to do that. The endoscopy. Then we do. So we mainly do HFN and HFNC.
Right. So these patients actually tend to desaturate. So we can make the general arguments that the tips that you provided. But I think it is best to have expertise around, and smaller tubes with the bougie or the stillet and this kind of intubating LMS with you, anticipating the worst complications, because some of these patients actually tend to desaturate first and end up in cardiac arrest. And then that becomes a very chaotic situations, especially in the COVID scenarios we have faced in a couple of cases.
So the most expert will do the intubation during the procedure. So we give chances to the most experienced operator, and with all the devices available.
True. So the expert or the senior most person in the team that time should be handling it. There's one more question: how to prepare a tachypneic PPH patient? How to prepare a tachypneic PPH patient for intubation, I believe.
So for tachypneic PPH patient, mostly this patient is tachypneic because of this postpartum hemorrhage and shock. So we have to optimize the patient with, if the blood products are available, well and good. Otherwise, we have to give rapid fluid bolus and also the vasopressors to optimize her BP. And then we should oxygenate the patient, pre-oxygenate to raise the oxygen saturation level. And then we can use the muscle relaxant and also the induction agent that will cause least hemodynamically instability.
Correct. So there is one question from Dr. Omer about what about use of muscle relaxant? Because in some practice, some practitioners do not use muscle relaxant in anticipation of difficult airway, especially in ARDS patients. So I think he's asking which kind of muscle relaxant will be better, or should we use it or not in ARDS patients?
In my lecture, I have already highlighted that most of our ICU doctors, particularly juniors, non-anesthesia doctors, are reluctant or frightened to use a muscle relaxant. But actually that makes a normal airway difficult. So if possible, if there is no other contraindication, then we should go always for a muscle relaxant. And if there is no contraindication, our preferable agent is suction methonium. But if there is any contraindication, we usually use atacurium or vecuronium, what is available.
Yeah, I guess we can use rocuronium as well. That is also quite fast acting, almost similar to succinylcholine onset of action. And the other tip, I mean, from my practice, I would like to share is like this kind of patients, if one is hesitant to use muscle relaxant in anticipation of probable difficult airway, one might as well just give low dose of some sedations with opioids or maybe dose of propofol or imidazolam according to the hemodynamics. Do a gentle laryngoscopy. See how if mouth opening the better compared to when you assess the patient before you administer the sedation. And if the mouth opening is good, and if you can, visualize part of the epiglottis and the glottis itself, then, it gives you certain level of confidence that if you're even paralyzing the patient, you will be successfully putting at least a small size tube, if not a, appropriate size of tube. So I think this is something in practice I usually share with my team to practice in the odd hours if they are not confident. So do this procedure, so that it gives you confidence. And as you said rightly, in many cases, actually not given relaxant makes the normal anatomy difficult. So you end up with more struggle and actually traumatizes the airway. And later on, we face more difficulty in winning these patients because they might be having glottic edema, vocal edema. Yeah, and later on also when you're, suppose you have tracheostomies and you're decannulating these patients, they also face different degrees of stenosis due to the airway trauma. So I think it's a very simple step. Just do a gentle laryngoscopy, see how much you can see. And that in most of the cases, it gives you a very fair idea about if you can proceed with the muscle relaxant or not. That's all. I do not see more questions, maybe just one more. Yeah, there is one question like practically in patients with severe metabolic acidosis, can we use lidocaine spray to obtain the reflexes? I think it's a very good question from Dr. Omer. Yeah.
I have one comment, Dr. Sharmili. I have one comment from, we learned a very good lesson from the COVID-19 that we have an intubation team in ICU. So that intubation team has a lead of the intubation team. It has an arm of the intubation team. People preparing the stuff. People preparing the patient. People preparing IV, vasopressor, muscle relaxant, drugs, everything. So I think going to preparation, intubation, after intubation checklist is absolutely perfect and make the job easier. And step 1, step 2, or option 1 and option 2, or plan 1 and plan 2 is absolutely making huge difference. And the learning curve, despite that we are senior or junior, we learn every day in our experience. Thank you.
Yeah, you rightly said that. That's so. I think Dr. Omer had a question. It's like practically in patients with severe metabolic acidosis, can we use lidocaine spray to obtain the reflexes? Dr. Hassan, would you like to answer this?
Yes. For severe metabolic acidosis, you can use a lidocaine spray or topical lidocaine because these patients are mostly moribund. They do not fight with you, do not have too much of reflexes. So you can well use it. And regarding one thing I have forgot to mention in my lecture, that giving sodium bicarbonate does not usually help. They may correct the blood pH, but there is intercellular pH, nobody knows. So better to go for a topical local anesthetic and go for awake intubation, preserving the spontaneous respiration, because their only way to compensate the severe metabolic acidosis is the respiratory compensation. And if we put any induction agent or muscle relaxant, that compensatory mechanism has gone and the patient will go for immediate cardiac arrest. So it is better to use a topical anesthetic.
Thank you. Thank you very much, Dr. Hassan. I think last question we take, and then I think we should proceed for the next session. That is again from the same doctor. What about using pressor dose of adrenaline in severely acidotic patients? I'm not sure about what he is actually wants to. What about using pressor dose of adrenaline in severely acidotic patients?
So we always do not give any bolus. We always give on infusion, maybe 5 to 10 micro gram per minute per or per hour, like that, according to the body weight and according to blood pressure. Our target is to achieve a mean arterial pressure of at least 70 or a systolic blood pressure of at least more than 90. So accordingly, we titrate and we give the dose. There is no fixed dose like that.
Yeah. I'd just like to share that the first vasopressor these days, if at all it's to be used, is the noradrenaline is the first choice, followed by vasopressin. Only in very exceptional cases would you have also bradycardia, and those are the cases where you want the chronotropy action. Probably adrenaline is used. Otherwise, adrenaline is not a vasopressor of choice for patients in shock because it causes tachyarrhythmias and it increases lactic acidosis. So many other fallacies are there. So it's not a vasopressor of choice. Thank you very much, Dr. Hassan. I think that was an exhaustive discussion and quite enlightening. Thank you very much. With that, I think we proceed to another interesting topic of today's sessions. Over to you, Dr. Yasser.
Thank you, Sharmila, for your moderating the first part. On behalf of Mega Online Learning, I would like to welcome the two top speakers on board today. But before I introduce my professor, few days ago, one of my friends is the examiner of our residency program. He spoke to me about the standard level of people in basic or the student, and they are very bad. And they tell me that you're teaching him ultrasound, but you don't teaching him how the machine working. I don't teaching him as the anatomy in a good way. So in the last few days, I try to go to the basic because really the tree can't survive without a root. And when Dr. Saad spoke to me about this, to present this session, I was very happy to go to the basic again with our prof, Coronero Biasvelli. Sorry for spelling the name. But the second speaker today is Professor Coronero Biasvelli. He's an professor and head of Department of Anesthesia and Intensive Care. Ako San Filippo Neri, member of Board of European Federalization of Medicine, President of World Society of Total Intravenous Anesthesia, President of Society of Clinical Risk Management in Italy, member of the World Commission on Safety and Equality, belong to WHO. I welcome our speaker, Professor, on the floor. And welcome, Professor, to Mega Online, and the floor is yours.
Thank you very much for your nice presentation. I would like also to thank Dr. Saad for this kind invitation and for this very important initiative. And also the other coordinator, Dr. Shamili, for the presence in this session. I would like to start immediately because is a long presentation. And so
vai in presentazione qua.
Ecco, just a second. Okay. I will talk about PK/PD of intravenous drugs for anesthesia, and with regard of the past, the present, and the future, just a very quickly overview. My disclosure is none to declare, of course, and I would like to remember, first of all, to me, that there are two pillars very important for a good anesthesia: to know very well the pharmacodynamics, and what we mean for pharmacodynamics is the study of the biochemical and the physiological effect of the drugs on the body and their mechanism of action. The second pillar is the pharmacokinetics, on the contrary, that studies the effect that the body's processes have on the drug, like absorption, distribution, metabolism, and elimination. Some of you can say, but is missing one pillar. Yes, we have no time tonight to talk about the pharmacogenetic. That is the last one that is very, very important. So just from this beginning, we can understand how very complicated is to proceed in a very good anesthesia way. What about the PK and PD interhuman variability? We know that we are not all the same, and we know also that the PK variability is around 35 to 70%, but greater is the pharmacodynamic variability that is from 300 to 400. And some study very recent says that this variability can increase to 1,200. So this is really important, and every day that we are going to VOA, we know that our patients, every patient is different from the other. So if we compare the doses of the drug and the effects that we have on our patients, we understand that this variability can produce different monitor parameters and also different clinics effect. Also by modifying the doses or talking about the pharmacodynamic effect. That is the problem, that one size does not fit all. We are different for many, many different reasons. So we have a great differentiation that we must take in account. Otherwise, when we read on the paper of the drugs, the dosage 0.0 this for all, this is a big mistake. It's not a good way to proceed. I will talk tonight about PK/PD new concept, TIVA, definition like past MCI, present TCI. But what is going on future closed loop TCI, open TCI for all intravenous drug and much more. We start from hypnotic and opioids pharmacodynamic interaction. It's not simple because the modern balanced anesthesia, we know that if we want unconsciousness and amnesia, we can use inhalation agents and or hypnotics. If we want muscular relaxation, we can use muscular relaxants. If we want the control of stress response, we can use analgesic drugs. Is it so simple? No, because if we use hypnotics, also we can enhance the action of opioids. Also, if we use hypnotic, we can enhance the action of neuromuscular blockers. And also, if we use opioids, we can enhance the action of hypnotics. Not only opioids plus hypnotics can enhance the action of neuromuscular blockers. And at the end, if we can use neuroblocker agents, they can enhance the action of hypnotics. So it's very, very complex. And from this different way of action, we can have a good anesthesia or a worse anesthesia for our patients. How we can define this interaction? In four ways: additive, synergistic, infra-additive or partial antagonist, or completely antagonist. The control of anesthesia components you can get from the set of three things. The first one, amount of drug administered. This is fundamental. The second one, the drug concentration in the effect site. And we can have measured or calculated. The third one is clinical and instrumental sign that indicate the depth of anesthetic reached. So we the first one. What and how much drug was administered? The first reply is that the concept only used for intravenous drugs as for anesthetic vapors. We think in terms of concentration, that means partial pressure or vapor pressure, and not of weight or volume used. The second concept is incomplete and insufficient because it does not take into account the pharmacokinetics. An equal amount of drug given in different individuals by age, gender, weight, and height can determine plasma and effect site concentration very, very different, and therefore clinical responses of different strength. Here we have a curve that shows us the probability of number of patients' responses. That means in this case, the 50% of probability, and we can change this probability, change the drug concentration, and the curve can change the curve. Here we have the effect concentration curve for each drug, because it's typical and it's different for every drugs. From one side, we have an effect. From the other side, we have a concentration. If we modify one of these parameters, we change the inclination and so the therapeutic margin of the drug. So we can go from EC50 to ED50. And this is important to know very well. If we want to represent these three different ways to combine the drugs, we need to understand the isobolograms. In the first one, in A, we have additivity, and we can see that is just the sum of the action of the first drug with the second one. And so the point where we have the maximum of additivity is this one. What about the synergism? It's completely different. In B, we have the representation of the curve. That means that it's not a simple sum of the two drugs, but is one drug that interact with another drug in a very few dosage, but is a starter that increase the action of the first one, of the second one. The last one is antagonism is represented. You can see that we can have a great dosage of the first one, a great dosage of the second one, but the curve is the point is very high, and we don't have the effect that we want to reach. Here is represented the sigmoidal concentration response relation for two drugs, but we can have for three drugs. And Minto and Vuik were the major experts of our society to study this effect. They publish a lot. And you can see how moving the dosage of drug A and drug B, the isobologram change, and we can find the better solution of the dosage of both. Here is represented surface showing relation to standard isobologram. The three-dimensional surface relating drugs A and B with a probability of no response. Conventional isobolographic analysis where for doses or concentration only produce the line at the 50 probability. You see, this line represents the 50 probability for the patients and correspond to this point of interaction of the two drugs, okay? As shown in the lower figure, and fails to capture the fuel surface shape. What we can say that, but above all, in periods of pairs, that it is not the addition of two persons, but the generation of a third individuality that is more than an addition. This is very important. It is a new idea, such as the water that is formed by hydrogen and oxygen, but is neither hydrogen nor oxygen. Here we have a double and triple pharmacokinetics, a pharmacodynamic synergism. And you can see this is represented by alfentanil, midazolam, with different concentration, with a propofol, the third one, or alfentanil. And we can see how change the dosage of the free drugs and is related to the effect that we want to keep in our patients, if we want a deep sedation or if we want to suppress more pain. Here we have other representation of the same concept, is the Isobologram of midazolam, propofol, alfentanil interaction, and this is a very important representation because we want to show that usually I saw in OR, I have 100 anesthesiologists with me, and most of them have an anesthesia that is like surfing, up and down, and also their coronary heart are up and down. But we want for our patients that the dynamic and kinetic state between effect and concentration must be very, very stable. In this way, we are sure that the cardiac performance, the respiratory performance, all the manifestation that we have in clinic during the surgery procedure must be very stable. Which are the new concepts in pharmacokinetics? First one is three-compartmental pharmacokinetics model with a further compartment that is called effect site. The second one is time to peak effect. The third one is KO and T-half KO. And the fourth one is context-sensitive half time. All these new concepts are very important because after that we talk about this new concept for intravenous anesthesia, also the inhalation anesthesia take this concept because the dynamic is similar. When we have a patient in OR on the bed, and we want to perform an anesthesia, we must consider that our patient is represented by three volumes. The central volume, that is this one, that represents the plasma. The second volume, that is volume 2, represents the organ with a high flow blood. The third volume, that represent the fat compartment that is very large, you can see, and the dimension of the free compartment is very different. But there are other things that I want to underline. This is the syringe. Our anesthesiologists say, please take a count, 1, 2, 3. This is the elimination of the drug. And we call this elimination clearance 1, that is a mathematical constant 1 to 0. This is another clearance. You see, the dimensions are very, very different. The elimination is small, usually, but the clearance too is very wide because the drugs don't act in the vessel. We know very well, but must pass through the high blood flow organs that are the brain, the heart, and the liver, the kidney, and so on. And we have another smaller pipe that is the way to go to the third compartment, that is the fat compartment. So we have different clearance, clearance 2 from the first to the second, and clearance 3 from the central compartment to the third compartment. But it's not the end of the story, because we know that our drugs act only in the brain. And so we have another compartment that we say effect site, that is a negligible volume because we have only receptor. It's impossible to measure. I publish the only work in the world that is very important, in which we put a probe near the extracellular fluid in cerebral brain of a human, and we succeed to measure what is nearest to the receptor about the concentration of the drug. And this is important because it's a mathematical constant that is the KO. That means the time needed by the drug to reach the brain. It's not the same for all the drug. It's different from any drug. It's different from any dosage. It's different from the speed in which you push your syringe. So there are many, many factors that can change your success in anesthesia. Here there is a representation of a morphine, and you can see how different are the real representation, the three compartments. We have a very small central compartment, in green, the effect site compartment, in which we have the strictly communication with the central compartment, the high flow blood concentration in the organs, and a big third compartment, because we know that when we are talking about morphine, we have an high accumulation in the third compartment. So it's not a friendly drug, but it's a long-acting drug, and we must calculate exactly the K, because we need to understand the pharmacokinetics of the morphine. This is the new model by Sarton. What is this? It's easy, not too much complicated. This is the logarithmic blood concentration curve. Here we have the logarithmic curve of intravenous injection of the drug. Just the first compartment, I mean the plasma compartment. If we make a different measure in different time, we have this line, this curve. In the beginning is very high because the concentration in the plasma became immediately very high, and then low by low decrease till to go down. What is this one? This one is the line of the concentration of the drug in the high blood flow organs. Is completely different. We have a beginning, a greater concentration, but a decline very quickly. And what is this? Is the curve, the line that represent the concentration of the drug inside the third compartment. You see that the concentration of the drug arises slower and later than the blood because needs time to go to fat and they decline very slowly. But which is the real curve that mix all together these three components is the green one. You see the concentration increase slower and maintain the concentration for a long time because it's just the result of these three components. If we go in pharmacokinetics and we take in account the K of this model, we can put all the data in the computer. And what is the result? Is this one, the curve of the concentration in the plasma. And usually we have this way, very quickly a rise of the concentration and in the same time a decrease and after a stabilization if we continue to inject the drug. But we can do more because if we measure the effect site concentration with the KO and put also this value in the computer, we have this kind of representation. In red, always the concentration of the blood, of the plasma, you see, quick increase, but in the brain, we need time. For this, the patient can say 1, 2, 3, 4, 5, and so on, because the drug needs to go and to reach the right concentration in the brain, not in the vessel, not in the other organ, not in the fat. And when we meet the 2 points, this is the right way to standardize the plan of anesthesia. And when we interrupt the injection of the drug, you see that the decrease in the blood, in the plasma is quickly, but in the brain is slower because needs to go by the KO, all the passage that I've done in the beginning. So it's a very important process. Why we need this pharmacokinetic model? The aim of the model is to establish the volume size of the compartments, volume 2, volume 1, volume 2, volume 3. The K-drug exchange rate of compartments, including the effect side, the clearances, this is achieved by comparing the variable of each patient's weight, age, sex, and age. It's different to make anesthesia to a 19-year-old patient to a 18 healthy patients. This is another important concept, the time to peak effect. What means? The time to peak effect has two main characteristics to define it. The time needed to reach the maximum concentration, the time that we call time to peak effect. And the other one is the maximum concentration reached. We are another simulation that we are doing in our simulating center in Rome. And you can see that if we perform the bolus of 0.5 microgram per kilo, this is following a Minto model, okay, of remifentanil, we have a very quick increase of concentration in the blood. Remember, in red is always the concentration in blood, in plasma, and that meet the concentration in the brain very quickly, only after 1 minute and 21 seconds. So the time to peak effect is very quickly. and depending from the drugs KO. For this is the quickest drugs that we can use. The concentration is 2 nanograms per milliliter for this dosage, and depending from administered dosage, speed of infusion, as I told before, and drugs KO. So many different way to reach this concentration. We don't use any more boluses, are too dangerous. So, summarizing, we can say that it depends on dosage of administered drugs, speed of drug infusion, drugs KO, and T-half KO, extremely rapid remifentanil once, volume of central compartment. Here just to, will be very practice to go back at home with something that you can remember. You can use everything. I saw from the previous lecture that was very interesting that you are using completely different drugs from us, but it's not important. It's important to know the pharmacokinetics and the pharmacodynamics of the drug that you use. So if you don't have remifentanil, it's the most friendly drugs because has a very short time of onset and a very rapid time of action, and is a very friendly drugs because is alpha context sensible. And after we see what is this concept, alfentanil is less rapid, just 2 minutes and 34 seconds. Fentanyl, model Schaefer, is 3 minutes and 31 seconds. Sufentanil you can use, but remember, it takes 6 minutes to have the clinical effect. So if you are mixing propofol, probably, because most of all are using propofol, remember that the hypnotic action of propofol takes 4 minutes and 20 seconds. So if you are using remifentanil in the same time, you have before the pain suppression and after the hypnotic action, because propofol is later coming. But if you use, for example, sufentanil, you have before the hypnotic effect of propofol and after the suppression of the pain. So, because these are timing that you cannot modify. I'm talking about KO and T-half KO. Very quickly, the clinical effect of a drug depends on the concentration at the effect side. That means on the brain. There is usually an hysteresis in clinical effect when the target blood concentration of the agent is increased and then decreased. The rate of the equilibrium between blood and effect side depend on several factors: the cardiac output, the cerebral blood flow, the lipid solubility. These factors are influencing the rate of delivery of the drug to the effect site. But there is another problem: the degree of ionization, that is the properties conditioning the rate of transfer across the blood-brain barrier. So KO is the rate constant that mathematically describes time course of blood to effect site equilibration. So we are measuring the time. Strictly speaking, we should use K10 or KE1, but they are very similar. So to simplify, we use only one. Use KEO to describe the rate of removal of a drug from the effect site out of the body. But the effect site is usually regarded as volumeless additional compartment, so that there is no need for separate constant describe the rate constant for movement in and out the effect compartment. This is another simulation, just to make you understand how we can modify our action during anesthesia. If we have the model pump, we can use Marsh model. But Marsh model, we have a fast KO, a slow KO. So I want to show how the KO, the time that measure the transportation of the drug to the similar cerebral compartment can change the anesthesia. You see that in the fast model, the match between the cerebral concentration and the blood concentration, it happens very soon. It means only after 1.2 minutes, and the T half KO is only 34 seconds. But if we use, for example, we have old patients that need a very carefully induction, a very slow induction for many factors, you see how we can change our KO, and the match between the cerebral concentration and the plasma concentration match later and with a lower concentration. So all the side effects that we can have during the induction of anesthesia can control much better. It depends from the situation of the patients. We said before, not all the patients are the same. In other words, the concentration at the effect site cannot be directly measured, and most of the time of blood concentration is not known either. The time course of change in the effect site concentration can be estimated from measure of a clinical pharmacodynamic effect, such as spontaneous or evoked EEG parameters. I want to go to the last important pillar of the new concept, that is context-sensitive half-time. What means? This is another simulation, just to explain very clear what want to show this concept that was very important. Here we have a constant in infusion of remifentanil. You can see we started from a concentration in the plasma, very low, 2.5, and after hour, okay, of infusion, the concentration is quite the same. It's just 3.1. That means that remifentanil we can infuse for day and day. I use, for example, in neurosurgery, in neurosurgical intensive care, because when the neurosurgeon comes to me and say, Quirino, please, I want to make an examination, I can stop the infusion and immediately the patient is still without the drug. So it can be very easy to examine the neurological state. What happens about propofol? You can see we start at 5 concentration microgram per milliliter, but after some hour of infusion, the same time of remifentanil, you see, okay, the concentration is increased to 5.6. That means that we have accumulation. I think that all of you knows that the steady state of propofol, it will be reached after 74 hours. That means that we can have a different dosage from the starting. But you can say, but I am injecting the same quantity of drug, I am perfusing, but the pharmacokinetics of propofol make an accumulation in our body. What what happens about all the other drugs. This is very famous representation in which you can understand the effect also in intensive care that can you have with the use of different drugs. You see that the remifentanil, after 9 hours of infusion, the dosage, the concentration is always the same. Different, as I told before about propofol, we have an increase, and so we have an accumulation. For alfentanil, we have a very strange curve, because in the beginning we have an increase in accumulation, and after we have a very flat way. But what happens with the thiopentone? I remember when I started, I am not anymore young, in neurosurgical intensive care, and we use a lot of thiopentone. It takes days to wake the patients, and much more with fentanyl. You see the accumulation of fentanyl, and this is a big problem, okay? Because you must use fentanyl, absolutely. But you must remember that this is the accumulation that these drugs has, and so change also the clinical effects. The same of midazolam. Why we have a lot of death with midazolam? Because a lot of gastroenterologists use midazolam for endoscopy examination, and they say, oh, we are doing another dosage, the same of before. It's a pity. They don't know about the pharmacokinetics, and they don't know an important principle, that midazolam is an accumulation. So from a patient awake, able to breathe, they go to a patient that sleep and without spontaneous breath. That means sometimes the death of the patients. So I would like to say to my moderators to stop me in any moment when they want, okay? Because I don't have the time. These are the old way to perform intravenous anesthesia that we call manual control infusion, that can do with boluses or in continuous contrast rate. The modern one is target control infusion, plasma TCI control, or effect site that is much better, TCI. I will go very quickly. We have no time, sorry, but it's impossible to explain pharmacokinetics and pharmacodynamic in so less time. The manual infusion of boluses always determines a progressively increasing blood concentration. And an effect site concentration sufficient for sedation is reached always in few minutes. However, if we follow with the same rate of infusion, we could reach a deep hypnotic dosage, as I told before, okay? Here is another simulation. We repeated propofol boluses in our center just to make to the student, to the young doctor, what happens. And we make the same dosage. So we think that the plasmatic concentration and the effect site concentration, that means in the brain, it's always the same. No, it's not true. You see how increase the concentration, and of course in the brain. That means that in the first 4 minutes, the effect site concentration is between 1.2, 1.6 microgram. In other words, we have a sedation. But after 10 minutes, like here, all change the panorama of our anesthesia. The effect site concentration is now 4 micrograms per milliliters. In other words, we have a hypnosis. So we lose the control of our airway. And if we don't know this, it will be a big trouble. okay? Here we have another example with remifentanil. We increase different boluses, 0.0 microgram kilograms for every 3 minutes for 1 hour. And you see the concentration is always the same. For this is called friendly drugs. We don't have a fear of opioids in intensive care or in anesthesia, because now we have drugs that we can manage very well without problem, okay? Which are the problem of manual control infusion at a continuous rate? First of all, the result is a progressive increase in drug concentration in plasma at the effect site. You see here, I showed just before, from sedation to hypnosis. The concentration change. With remifentanil, no at all. I go very quickly. I have no time to show why. The same continuous infusion at a constant rate of drug following the different models seems to determine very different effect site concentration at a steady state in individuals differing in age, gender, weight, and age, because of the compartments differing volumes and clearance. This is the second problem. Don't take in account this situation. Probably in another, if Dr. Saad invite me again, we can go deeply in this explication. I try. Just a sec. Okay. And why happens this? Because we need to know very well the covariates. What do we mean in anesthesia about covariates? We say that we are not all the same. For example, one very important covariate is the age. You see how making the same concentration of the drug, how these covariates change the concentration in our blood. And you know, I'm sure, because when you go in OR, you know, don't make the same concentration to 80 old patients like an 18 patients. But this is important. The other covariates are the weight, and also the other one is the age, but also the gender. You see how it can change the value of the concentration following these covariates. So I use a lot of TCI, of course. This is what we are doing now. I am at the conclusion. Sorry, because probably I take too much time, but just very few words. You see, this is one of the newest. You can use 2 drugs. Usually we use propofol and remifentanil, and you can go directly to measure the effect site. That means this in green, because if you control the yellow one is the plasma concentration. And you see, you can also understand which is the EC50 that is represented by this green zone. If the lower zone is the EC50 for the patients, in the upper one is the EC19. So you can be sure of the interaction of the 2 drugs. I would like to thank and sorry for taking so much time and for your patience. Thank you so much.
Rosso.
Thank you, Prof. Really, it is like a big meal, like to eat a camel in 30 to 40 minutes. We know that. Even for me, as I understanding, I can't be in harmony with the lecture. I need to get many hours to digest the lecture, and we need to see you, inshallah, in the near future, because all of us, we think we get rid of physiology, anatomy, and pharmacology when we finish the medical school. But in our specialty, sorry, in our specialty, it is needless to say that we will not get rid of this stuff like physiology, anatomy, and pharmacology, because the anesthesia is the practical physiology and pharmacology, and regional anesthesia is practical anatomy. And for any question, if you have any question, you can put your question in question and answer bottom here. And really, we need to see you again, Prof. And this is after permission of Dr. Saad, because we need to know more about this subject about pharmacology, pharmacodynamic, pharmacokinetic, and pharmacogenetic. So
it will be my pleasure.
Inshallah, thank you.
Open invitation, Prof. For you, and all the learning program is yours at the moment. So we are delighted to have you again and again and again. And any talented speakers like yourself, all welcome to teach us all over the world. So we have this program reach more than 70 countries all over the world. We are so proud that this program is consistent and every week, and everybody's waiting for it. Thank you.
Thank you very much, Dr. Saad. But I don't teach. I just make a refresher course with my colleagues because they are cleverest than me, I'm sure.
That's it.
When we take in the medical school, really.
In the chat box, can we take that? Yeah, there's a question for Dr. Aquino. Are there different? Are there different models for using TCI, and which one would you prefer, Dr. Quirino?
Yes. For example, it was interesting about the intubation that my colleagues took in a very expert way before. For example, when we have a maxillofacial trauma, very, very severe, we don't use any relaxant or any drugs, but just remifentanil, because with the remifentanil we are able to suppress the pain, and we can open and we try to find, because usually are very, very difficult intubation, and my colleague Dr. Hassan can confirm. And we don't use hypnotics, because if the patients lose the control of a very brief, we get into trouble. But if we can miss the intubation with this technique, and we don't use muscle relaxant, because with remifentanil we have an easy intubation without no problem. So we are try to, how I can say, to use the better aspect of the pharmacopoeia that we have. We are using the good side of the drugs, and we try to minimize the side effect. Okay.
Sorry, another question for came from our Qatar contribution, Dr. Muhammad Sulaiman. He said, what is the future of closed loop anesthesia?
Thank you. It's a very interesting question. We are studying. Our society is doing a very, very model for automatic anesthesia. But we still are very able to control the deep of anesthesia. One component, as I show in the beginning of my presentation, we are able to control the pain component. Is very easy. But what we are not able still to control in the correct way is the stress situation during the OR. During the operation. We have a different technique that we are using, but no one of this technique can say us if the patient is in the right level, in the right balance between stimulus and effect. That means that we need some more study to implement the situation, because also with EEG, with other techniques that are very complicated, we don't have a good result. We just go very close to our target, but I think that we need to computerize. We must put our experience all together and have a big database. Only with this we can, because I told before, we are so different each other, and if we put also the pharmacogenomic, it becomes so complicated. Why, for example, morphine can act in some ethnic group, in other no. And also other drugs, anti-inflammatory, have a good action in some group, in other less, because of course the liver produce a different way of metabolism of this drug. So I think that only with a big data set we can summarize something that we can apply to everyone, or mostly, not everyone. Okay.
Dr. Sharmila,
I think a couple of more questions. I can see I think it's a basic question for how to prevent the lack of analgesia after we stop remifentanil infusion with such PK and PT. I think that's a very practical question.
How to prevent, sorry?
How to prevent the lack of analgesia after we stop remifentanil.
Yes. Thank you for this very important question. I would like to thank the colleague. Now, remifentanil teach us, anesthesiologists and intensivists, that when we stop remifentanil, the patient is without cover for pain. So we must do something. And usually we add the morphine, but we need to start to implement our cover with half an hour before to stop remifentanil. So when the action of remifentanil finish, we have just the top, the time to pick off of morphine, and our patient is quiet and have no pain at all. So I think that remifentanil was very important, because teach me for the first how to improve and to combine different way of analgesia, because we know that the action of remifentanil stop immediately, and so we need to learn the time to peak effect of all the other analgesic.
Yeah, thank you. We have another question. I don't know, some of our colleagues asking about can we mix remifentanil and propofol in the same syringe, and at what concentration?
I say that anesthesiologists can mix everything. Okay, also mine. I say, why you are doing this? I say, because I used to do this. My suggestion is to use few drugs that you know very well in the right concentration for the right patients, and not to be sure that the action of the two drugs that you are using are or not contrastant. You have you have or an addition or a synergetic effect, but not the contrary, because I'm sorry, I saw also this sometimes, and this is not good for the patients, because we have in this occasion only side effect.
Yeah, this is my question to you, Prof, because from your presentation, I understand that every person is unique and have a different pharmacodynamic, pharmacokinetic, pharmacogenetic, like fingerprints. how can you adjust your anesthesia or TCI or intravenous anesthesia with everyone, and everyone is different? How can you make it different, even not as a person, different age, different sex, different in organ functions?
Thank you for this question, because it's really important. This is what I say, the attitude, the sensibility that each of us mature after many years of practice. And so is able to understand also the healthy status of the patients, start from this. The genomic and the genic of the patients belongs to particular group. And the other things that we have not talked about tonight is the kind of surgery procedure. For example, in neurosurgical, there are times that in which the patients don't feel pain. For example, when the surgeon open take off the scalp, after that, the brain is totally without pain. So we can modulate in different way the anesthesia without any side effect. For example, also for abdominal surgery, we know that some time of this surgery can provoke a high pain. And for this, TCI is very important to come to your question, because we can modulate the velocity of the infusion of the drug, the concentration of the drug, and we can modulate this action with our monitor, the frequency, cardiac frequency, the depth of anesthesia, all the other reaction of the neurovegetative system, and so on. This is important because in this way you can personalize the anesthesia. For this, I take part with the program of the other presidents of US about the personalized medicine, Obama, because I think that he understands what is going on in the modern medicine. We are different and must be different the approach, but unfortunately, another president say, no. Okay.
Dr. Sharmila, I think we can conclude now because we don't have more question. And for my colleague, Dr. Sharmila, to say last word in the session. And thank you very much.
Yeah.
Thank you.
Thank you, Dr. Yassir, and thank you, Prof. Curino, for excellent sessions, and thanks, Dr. Ahsan, for his very informative tips on intubation critically ill patients in intensive care unit. I think both of you did wonderful today, and the discussion was quite engaging. And again, immense thanks goes to Dr. Saad Mahdi and to Dr. Yassir for moderating so well. Thank you.
Thank you so much for speakers and the moderator tonight, and many thanks for our colleagues who are attending this webinar and supporting this webinar. We are nearly 100 people from all over the world supporting the program tonight. Excellent speakers tonight, and I am overwhelmed about the kind of the discussion and the wealthy materials and the open invitation for Dr. Ahsan Ahmed and Prof. Kinroni for the next lecture. And I promise you, I'm going to communicate with him, sending him an email tonight, and getting the lecture as soon as we can. Next week, 24th of October, we have Prof. John Doyle and Dr. Adel Hamada for two different lectures next week. From me and from my colleagues tonight, good night tonight, everybody, and thank you so much.